Vitamin D in Jordanian infants. Najwa Curry Bolos, Professor of Pediatrics and Infectious Disease, Jordan University Hospital. Outline about vitamin D. Sources of vitamin D. Classical action on bone. Non-classical functions. Normal vitamin D intake. PTS at risk of vitamin D deficiency. Clinical manifestations of vitamin D deficiency. Laboratory diagnosis of vitamin D deficiency. Treatment. Status of vitamin D in Jordan with special reference to children. Prevention of vitamin D deficiency. Vitamin D rickets first described in the 17th century. Relationship to fat-soluble vitamin and dietary vitamin D in early 20th century. This is the only vitamin that is synthesized by human body by interaction of skin with sunshine. Many genes encoding proteins that regulate cell proliferation, differentiation, and apoptosis are modulated in part by vitamin D. Vitamin D pathways for the two sources of vitamin D. Definition: Vitamin D2, ergosterol plant sources. Vitamin D3 cholecalciferol from skin. Also manufactured from lanolin. 25,0H vitamin D calcidiol. 1,25O vitamin D calcitriol. Vitamin D actions: Vitamin D promotes calcium absorption in the gut. Maintains adequate serum calcium and phosphate concentrations to enable normal mineralization of bone and prevents hypocalcemic tetany. It is also needed for bone growth and bone remodeling by osteoblasts and osteoclasts. Vitamin D actions: Actions on bone: increased bone density, increased calcium and PO4 deposition, decreased osteoporotic fracture. Vitamin D actions: Immune response: increased regulatory T cell, increased oxidative burst, increased cathelicidin, decreased cytokine release. Vitamin D actions: Pregnancy, decreased preeclampsia, decreased myopathy, decreased calcium malabsorption, decreased bone loss. Decreased risk of CS. Mulligan et al. American Journal of Obstetric and Gynecology, 2010. Vitamin D action: Pancreas, decreased insulin resistance, decreased type 1 diabetes, increased insulin secretion. Vitamin D actions: Children, decreased SGA, decreased risk of rickets, decreased risk of hypocalcemia, infantile cardiomyopathy if deficient, decreased severity of RSV infection, increased incidence of asthma if deficient. Sources of vitamin D: Normal diets less than 10%. Must be synthesized by the skin or taken as dietary supplement. Skin must have direct exposure to sunshine 10 to 15 minutes at noon hours. Exposure not acceptable behind glass. No sunblock applied. Dark-skinned people need more exposure to have same level of vitamin D. Vitamin D in the newborn. Highly correlated with vitamin D in the pregnant mother. Fetus totally dependent on maternal sources of vitamin D and calcium. After birth, breast milk is a very poor source of vitamin D, only 10 to 40 units/liter. Hence must supplement infants very early in life. Infants need 400 IU per day. Even formula-fed babies need vitamin D supplementation. Vitamin D status: 1 mol/liter equals 0.4 nanograms/ml. Vitamin D levels are inversely related to parathormone levels. These level off at 30 to 40 nanograms determined to be the adequate range. Calcium absorption increased at greater than 30 nanograms. Vitamin D25O levels and vitamin D status. Definition: less than 20 nanograms/ml, less than 50 mm/L deficient. 20 to 30 nanograms/ml 50 to 75 mm/L insufficient. Greater than 30 ng/ml greater than 75 mm/L normal, optimal. Greater than 150 nanograms/ml greater than 375 mm/L toxic. Vitamin D sources: dietary supplementation, sunlight. Wavelength 290 to 315 penetrates the skin and converts 7-dehydrocholesterol to pre-vitamin D3. Any excess of these is destroyed by sunlight. There is no toxicity from the sun exposure. Vitamin D from the skin and dietary sources is metabolized by the liver to become 25O, and the final 1-hydroxylation step occurs in the kidney to lead to 1,25O vitamin D, which is the active form. This final renal step is highly regulated by parathormone and serum calcium and PO4 levels. Sun exposure and vitamin D. Ultraviolet, UV-B radiation with a wavelength of 290 to 320 nanometers penetrates uncovered skin and converts cutaneous 7-dehydrocholesterol to pre-vitamin D3, which in turn becomes vitamin D3. Adequate intake of vitamin D per day. Infants less than 12 months 400 IU. Children greater than 1 year 600 IU. Adults, pregnant 600 IU. Greater than 70 years 800 IU. Mainly obtained from fish and fortified foods or exposure to sunshine. 1 microgram equals 40 units. People at risk of vitamin D deficiency. Breastfed infants. Older adults. People with limited sun exposure. People with dark skin. People with fat malabsorption. People with BMI greater than 30. Causes of vitamin D deficiency in children and adolescents. Reduced intake or synthesis of vitamin D3. Being born to a vitamin D deficient mother, dark-skinned women, or women who actively avoid exposure to sunlight or are veiled. Prolonged breastfeeding. Dark skin color. Reduced sun exposure, chronic illness or hospitalization, intellectual disability, and excessive use of sunscreen. Low intake of foods containing vitamin D, causes of vitamin D deficiency in children and adolescents. Abnormal gut function or malabsorption. Small bowel disorders, e.g., celiac disease. Pancreatic insufficiency, e.g., cystic fibrosis. Biliary obstruction, e.g., biliary atresia. Causes of vitamin D deficiency in children and adolescents. Reduced synthesis or increased degradation of 25OHD or 1,25O2D. Chronic liver or renal disease. Drugs, rifampicin, isoniazid and anticonvulsants. Osseous signs of vitamin D deficiency, common to less common. Swelling of wrists and ankles. Rachitic rosary, enlarged costochondral joints felt lateral to the nipple line. Genuvarum, genuvalgum or windswept deformities of the knee. Frontal bossing. Limb pain and fracture. Craniotomies, softening of skull bones, usually evident on palpation of cranial sutures in the first 3 months. Hypocalcemia, seizures, carpopedal spasm. Myopathy, delayed motor development. Delayed fontanelle closure. Delayed tooth eruption. Enamel hypoplasia. Raised intracranial pressure. Secondary hyperparathyroidism. Radiological features. Cupping, splaying and fraying of the metaphysis of the ulna, radius and costochondral junction. Coarse trabecular pattern of metaphysis. Osteopenia. Fractures. Treatments of hypocalcemia. Less than 1 month of age. 10% calcium gluconate, half a milliliter/kg, max 20 milliliters, intravenously over 30 to 60 minutes. Calcium, 40 to 80 mg/kg/day, 1 to 2 millimoles/kg/day, orally in 4 to 6 doses. Calcitriol, vitamin D3, 50 to 100 nanograms/kg/day or in 2 to 3 doses until serum calcium level is greater than 2.1 millimoles/L or 8 mg/L. Treatment of vitamin D deficiency. Acute management. Age. Less than 1 month. Vitamin D, 1000 IU, 25 grams, daily for 3 months. Maintenance. Vitamin D, 400 IU, 10 grams, daily or 150 IU, 3750 grams, at the start of autumn. Monitoring. 1 month, serum calcium and alkaline phosphatase. 1 to 12 months. Vitamin D, 3000 IU, 75 grams, daily for 3 months, or 300 IU, 7,500 grams, over 1 to 7 day. 3 months, serum calcium, magnesium, phosphate, alkaline phosphatase, calcidiol, parathyroid hormone. Wrist X-ray to assess healing of rickets. Annual, calcidiol. Greater than 12 months. Vitamin D, 5000 IU, 125 grams, daily for 3 months, or 500 IU, 15 plus gram, over 1 to 7 days. Calcitriol, 1, 25 vitamin D, calcidiol, 25 vitamin D, adequate calcium intake. Age. Calcium intake. 0 to 6 months. 210 milligrams. 6 to 12 months. 270 milligrams. 1 to 3 years. 300 milligrams. 4 to 8 years. 800 milligrams. 9 to 18 years. 1,300 milligrams. Recent studies on vitamin D in Jordanians. 2011, Bhatia et al. And NutriMet. 37% females were deficient. 5.6% of males were deficient. 2010 Abdul Razak, Pediatric International. 28% deficient, 16% severe. Association with breastfeeding was found. National Micronutrient Survey 2010. Women deficient less than 12 nanograms/ml greater than 50%. Children 1 to 6 years less than 11 nanograms/ml 10 to 20%. Curry Bolos et al., JMJ, 1 to 6 years also 30% insufficient. Study on newborn and pregnant mothers and vitamin D. Ongoing study of vitamin D in newborn. More than 3,000 vitamin D levels obtained in the first day of life. Range from 0.115 nanograms/ml. Cutoff for this is 20 nanograms/ml. 99.8 were vitamin D deficient below 10 nanograms/ml. Mean was 3 nanograms/ml. 100 mothers who were tested also had decreased vitamin D level, almost uniformly less than 10 nanograms/ml. Vitamin D levels in newborns in Jordan. Overwhelming majority greater than 99% are deficient less than 15 nanograms/ml. What should be done? Increased sun exposure, not consistent with current social norms. Supplementation of the different age groups. Fortification of food items, most useful. Which food item? Oil preferable but flour more feasible since it is cheaper and is the main staple food. For infants must give vitamin D drops. Pregnant women should be studied further and supplementation during pregnancy must be done. Thank you. Vitamin D activity. Activated T lymphocytes and macrophages have increased VDR. This stimulates antibody-mediated and phagocyte-mediated cytotoxicity. Clinical association with asthma and RSV of cord blood vitamin D is deficient. Increased risk of cesarean section also with vitamin D deficiency. Metabolism of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D for non-skeletal functions. Figure 2. Metabolism of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D for non-skeletal functions. When a macrophage or monocyte is stimulated through its toll-like receptor 2,1, TLR2/1, by an infectious agent such as Mycobacterium tuberculosis or its lipopolysaccharide, the signal upregulates the expression of vitamin D receptor, VDR, and 25-hydroxyvitamin D1-alpha hydroxylase, 1-AHACE. A 25-hydroxyvitamin D, 25-OD, level of 30 nanograms per milliliter, 75 nmol per liter, or higher provides adequate substrate for 1-AHACE to convert 25-OD to its active form, 1,25-dihydroxyvitamin D, 1,25-O2D. 1,25-O2D travels to the nucleus, where it increases the expression of cathelicidin, a peptide capable of promoting innate immunity and inducing the destruction of infectious agents such as M. tuberculosis. It is also likely that the 1,25-O2D produced in monocytes or macrophages is released to act locally on activated T lymphocytes, which regulate cytokine synthesis, and activated B lymphocytes, which regulate immunoglobulin synthesis. When the 25-OD level is approximately 30 nanograms per milliliter, the risk of many common cancers is reduced. It is believed that the local production of 1,25-O2D in the breast, colon, prostate, and other tissues regulates a variety of genes that control proliferation, including P21 and P27, as well as genes that inhibit angiogenesis and induce differentiation and apoptosis. Once 1,25-O2D completes the task of maintaining normal cellular proliferation and differentiation, it induces expression of the enzyme 25-hydroxyvitamin D24-hydroxylase, 24-AHACE, which enhances the catabolism of 1,25-O2D to the biologically inert calcitroic acid. Thus, locally produced 1,25-O2D does not enter the circulation and has no influence on calcium metabolism. The parathyroid glands have 1-AHACE activity, and the local production of 1,25-O2D inhibits the expression and synthesis of parathyroid hormone. The 1,25-O2D produced in the kidney enters the circulation and can downregulate renin production in the kidney and stimulate insulin secretion in the beta-islet cells of the pancreas. Holochem F. N. Engel J. Med 2007 357 to 266 to 281. Synthesis and metabolism of vitamin D and the regulation of calcium, phosphorus, and bone metabolism. Figure 1. Synthesis and metabolism of vitamin D and the regulation of calcium, phosphorus, and bone metabolism. During exposure to solar ultraviolet B, UVB, radiation, 7-dehydrocholesterol in the skin is converted to pre-vitamin D3, which is immediately converted to vitamin D3 in a heat-dependent process. Excessive exposure to sunlight degrades pre-vitamin D3 and vitamin D3 into inactive photoproducts. Vitamin D2 and vitamin D3 from dietary sources are incorporated into chylomicrons and transported by the lymphatic system into the venous circulation. Vitamin D, hereafter D represents D2 or D3, made in the skin or ingested in the diet can be stored in and then released from fat cells. Vitamin D in the circulation is bound to the vitamin D binding protein, which transports it to the liver, where vitamin D is converted by vitamin D25 hydroxylase to 25-hydroxyvitamin D, 25-OD. This is the major circulating form of vitamin D that is used by clinicians to determine vitamin D status. Although most laboratories report the normal range to be 20 to 100 nanograms per milliliter, 50 to 215 mol per liter, The preferred range is 30 to 60 nanograms per milliliter, 75 to 115 mol per liter. This form of vitamin D is biologically inactive and must be converted in the kidneys by 25-hydroxyvitamin D1 alpha-hydroxylase, 1-ahase, to the biologically active form, 1,25-dihydroxyvitamin D, 1,25O2D. Serum phosphorus, calcium, fibroblast growth factor 23, FGF23, and other factors can either increase, plus, or decrease, the renal production of 1,25O2D. 1,25O2D decreases its own synthesis through negative feedback and decreases the synthesis and secretion of parathyroid hormone by the parathyroid glands. 1,25O2D increases the expression of 25-hydroxyvitamin D24-hydroxylase, 24-ahase, to catabolize 1,25O2D to the water-soluble, biologically inactive calcitroic acid, which is excreted in the bile. 1,25O2D enhances intestinal calcium absorption in the small intestine by interacting with the vitamin D receptor retinoic acid X receptor complex, VDRXR, to enhance the expression of the epithelial calcium channel, transient receptor potential cation channel, subfamily V, member 6, TRPV6, and calbindin 9K, a calcium-binding protein, CABP. 1,25O2D is recognized by its receptor in osteoblasts, causing an increase in the expression of the receptor activator of nuclear factor kappa B ligand, RANKL. RANK, the receptor for RANKL on preosteoclasts, binds RANKL, which induces preosteoclasts to become mature osteoclasts. Mature osteoclasts remove calcium and phosphorus from the bone, maintaining calcium and phosphorus levels in the blood. Adequate calcium, Ca2+, and phosphorus, HPO4-2-, levels promote the mineralization of the skeleton. Holochem F. N. Engel J. Med 2007 357 to 266 to 281. The immune system and vitamin D. Calcitriol, I-25, has immune modulating function. First described with sarcoidosis. Calcitriol produced by macrophages in the granulomas lead to hypercalcemia. Calcitriol also inhibits proliferation of MDB cells. This is not subject to feedback as is the kidney. Vitamin D deficiency has been shown to increase the risk of infection, especially respiratory infection. Vitamin D functions. Vitamin D has other roles in the body, including modulation of cell growth, neuromuscular and immune function, and reduction of inflammation. Many genes encoding proteins that regulate cell proliferation, differentiation, and apoptosis are modulated in part by vitamin D. Serum concentration of 25OD is the best indicator of vitamin D status. It reflects vitamin D produced cutaneously and that obtained from food and supplements and has a fairly long circulating half-life of 15 days. Sun exposure and vitamin D. Complete cloud reduces UV energy by 50%, shade. UVB radiation does not penetrate glass, so exposure to sunshine indoors through a window does not produce vitamin D. Sunscreens with a sun protection factor, SPF, of 8 or more appear to block vitamin D producing UV rays.